welcome to the Deep Dive. Today we are unpacking a topic that is, it's arguably one of the most challenging and historically misunderstood areas in all of medicine, schizophrenia.
Yeah.
You've shared some incredibly detailed, really high-level source material with us, and it covers everything from the 19th century foundations right up to the modern principles of treatment failure.
That's absolutely right. And for this deep dive, our mission is to act as your expert guides. We're going to distill this really dense clinical landscape into the essential need-to-know nuggets. We're moving beyond just the textbook definitions here.
Right.
We need to understand not just the clinical criteria for a diagnosis, but also the critical factors that predict a patient's future, the prognosis, and maybe most importantly, what the playbook looks like when the initial treatments just don't work.
So this journey is really structured around clinical decision-making. We're going to define the foundational concepts, and then we'll look at the sharp contrast between better and worse prognostic factors. And finally, we'll dive deep into the specific strategy for handling treatment-resistant schizophrenia. It's like a roadmap for understanding the full patient journey.
Exactly. And to understand where we are today, we have to start with the two giants who really framed the entire conversation. We begin with Emil Kraepelin. His contribution was essentially defining the outcome.
Kraepelin.
Yeah.
He was the great observer, right?
Mm-hmm.
Looking at the long-term trajectories, he categorized these severe mental illnesses based on where they ended up.
Precisely. Kraepelin established that some severe illnesses had a really poor prognosis, defined by chronic progression and significant cognitive decline. He called this dementia praecox.
Which means early dementia.
Right. And critically, he contrasted this with what he saw as manic depressive psychosis, which had a much better, more episodic course.
Okay, so Kraepelin gave us the importance of prognosis, where we're going. But then Eugene Bleuler came along, and he fundamentally shifted the focus from the outcome to the core psychological deficit itself.
Bleuler's the one who coined the term schizophrenia, the splitting of the mind. And he wasn't talking about a split personality, but a fragmentation within the core psychological functions. He gave us the famous diagnostic 4As, which were, they were revolutionary because they looked at the subtle, persistent changes in behavior and cognition, not just the dramatic psychotic symptoms.
Let's elaborate on those 4As for a minute, because they really represent the internal core of the illness.
Okay, so the 4As are autism, and here that means social withdrawal, a preoccupation with inner thoughts. Then ambivalence.
The simultaneous presence of opposing emotions. It makes decision-making almost impossible.
Exactly. Then affective blunting flattening, which is the reduction in emotional response. And finally, association, the fragmentation or loss of logical thought connections.
That last one, association, that feels key to Bleuler's whole view. It suggests a fundamental breakdown in how the brain links ideas together. And here's a crucial insight from our sources. Auditory hallucination is not one of Bleuler's original 4As.
That's a great point. The core pathology, in his view, was always the thinking process itself. And that distinction is still highly relevant today because it reflects the enduring challenge of the disorder. When we move to modern clinical definitions, our sources clearly separate the symptoms into two categories, and each is linked to a major biological pathway.
Okay, let's unpack the biology and the symptom landscape. We have the positive symptoms. I tend to think of these as things that are overtly added to a person's reality, and these symptoms are linked to an overactivity in the mesolimbic pathway, correct?
That is the biological connection, yes. Overactivity there gives us the dramatic, obvious symptoms: delusions, hallucinations, disorganized thinking, and disorganized or catatonic behavior. These are traditionally what clinicians focus on first because they are generally the most responsive to initial medication.
But the real functional burden, it seems, comes from the negative symptoms. These are things that are taken away from a person's functional capacity, and they're associated with the mesocortical pathway and cognitive dysfunction.
Exactly. The mesocortical pathway is associated with those deficits that drive long-term disability and poorer outcomes. We're talking about apathy, which is lack of motivation, alogia, or poverty of speech.
Attention deficits, anhedonia, the inability to feel pleasure.
And affective blunting flattening. For you, listening, this is the first crucial takeaway. The negative symptoms are typically the most difficult part of the disorder to treat pharmacologically.
So how do we use this clinically? What are the actual rule book requirements, the duration criteria, to finalize a diagnosis?
Well, the clock is definitely ticking when we talk about diagnosis, but the required duration varies a bit. The ICD, the International Classification of Diseases, it requires symptoms for at least 1 month.
But the DSM, which is the standard used widely in the U.S., extends that quite a bit.
It does. The DSM requires symptoms for 6 months or longer, and in both cases, you need 2 out of the 5 core symptoms, and this is critical, at least one of those 2 symptoms has to be a positive symptom.
And finally, a quick nod to the historical clinical tools. Kurt Schneider's first-rank symptoms, or FRS. These are classic, highly specific signs that often point directly toward a psychotic disorder.
They are powerful indicators of thought intrusion and control. They fall into categories like specific auditory hallucinations, like hearing voices in the first, second, or third person, and the maid phenomena.
The maid phenomena always struck me as just so deeply insightful into the patient's experience.
Yes. That's the feeling of having one's own impulses or will or affect being controlled or made by some outside force. It's also paired with the thought phenomena, the belief that thoughts are being inserted into your mind, broadcast to others, or even withdrawn entirely.
And when you combine that with somatic passivity or a delusion of control, you have a patient who truly believes they are not autonomous. Okay, let's unpack this. We've established the clinical picture. Now we shift to where we're going, the prognosis. For you, the listener, understanding these factors helps explain why 2 people with the exact same diagnosis can have wildly different life paths.
This section is absolutely crucial because prognosis relies on so much more than just biology. It involves speed, support, genetics, and environment. We can synthesize the factors by looking at them in contrasting pairs.
Let's start with the onset. Speed really matters here, doesn't it?
It absolutely does. An acute onset where the symptoms develop rapidly is associated with a better prognosis. It often suggests the system was, triggered maybe by an environmental stressor. This might mean the baseline underlying pathology is less severe. The opposite is true for a gradual, insidious onset, which suggests a deeper, more inherent process leading to a worse prognosis.
We also see that the timing of the first presentation is hugely significant.
It is. A late age of onset correlates with a better path forward, while an early onset is much tougher. It often leads to more protracted educational and social deficits. We also see that the presence of a clear preceding stressor before the onset points to a better prognosis compared to an absence of any stressor.
In linking back to what we just discussed, the symptom profile itself is predictive of the future.
This is one of the most critical factors. If a patient presents with more positive symptoms, the prognosis tends to be better.
Because those mesolimbic symptoms are often responsive to medication.
Exactly. If, however, the patient presents with a predominance of those hard-to-treat negative symptoms, they face a significantly worse path toward functional recovery. That's a key predictor.
I found the nuance in the family history fascinating. It's not just a simple binary check for, does mental illness run in the family?
No, it's much more specific than that. If the family history is dominated by mood symptoms like bipolar disorder, that strangely correlates with a better prognosis in the patient. But a direct, clear family history of schizophrenia symptoms points to a worse trajectory. It implies a more pervasive genetic risk profile.
And we can't ignore the external actionable factors, the relationship between the patient and their environment. This is directly tied to compliance and support.
These are the protective layers. Patients who are compliant with their medication and have a stable, supportive family structure are just far better positioned to maintain stability and function.
And conversely.
Conversely, noncompliance and an absent family support system dramatically increase the risk of relapse and instability, and that often results in multiple hospital admissions.
Which leads us to comorbidities, the other co-occurring conditions that just pile up the complexity.
Every additional factor drags the prognosis down. The presence of substance abuse, a premorbid personality disorder, a documented neurodevelopmental delay, or a history of obstetric complications like perinatal asphyxia.
All of these things.
All these signal a significantly increased risk for a worse outcome. This really highlights that managing schizophrenia is often about managing these compounding clinical complexities.
Here's where it gets really interesting. Once the diagnosis and prognostic factors are all mapped out, we turn to the treatment playbook. And our sources detail a clear, stepwise approach, starting with the 2 generations of antipsychotics.
Antipsychotics are the cornerstone of treatment, and they're defined by their receptor action. The typical or first-generation drugs were the first on the scene. Their mechanism is a powerful sort of blunt force blockade of all D receptors.
And the unavoidable trade-off for that blanket blockade is a really high risk of those movement disorders we call extrapyramidal side effects, or EPS.
Exactly. And that high EPS risk led to the development of the atypical or second-generation antipsychotics. These were designed to be a bit smarter, working on both 5-HT, which is serotonin, and D-Eros receptors.
And the key mechanism that separates them from the typicals is the way they interact with dopamine, the fast dissociation from the D-Eros receptor.
That fast dissociation is crucial. It means the drug doesn't stick around on the D-Euro receptor for a long time. It modulates the dopamine system without shutting it down entirely, and that is thought to be the reason why they cause less prominent EPS. However, they introduce their own set of very serious trade-offs.
So we swap movement problems for metabolic problems.
Correct. The atypicals carry the risk of significant metabolic side effects. Extreme weight gain, high sedation, dyslipidemia, hyperglycemia. It means clinicians are constantly trading off the risk of acute motor side effects against long-term cardiovascular and metabolic risks.
Now, let's talk about the specific failure state. Treatment-resistant schizophrenia, or TRS. What is the clinical threshold for labeling a patient as resistant?
TRS is a very strict definition that requires a high degree of clinical failure. It's defined as a patient being refractory or unresponsive to 2 different antipsychotics.
And each of those has to be administered at an adequate dose and for a sufficient duration.
Exactly. At that point, you can say the standard treatment pathway has failed.
And what is the unequivocal treatment of choice once that threshold has been met?
That is clozapine. It remains the most effective antipsychotic available, and it offers a significant advantage in cases of established treatment resistance when all other typical and atypical agents have been exhausted.
But the effectiveness comes with a major, potentially lethal caveat.
It does. For you, the listener, the key thing to remember about clozapine is the required very rigorous monitoring due to the risk of granulocytosis, a potentially fatal drop in white blood cell count.
And on top of that,
Other side effects include heavy sedation, significant hypersalivation, a lowered seizure threshold, which is dose-dependent, and, of course, the standard metabolic side effects.
finally, we need to address treatment duration.
Yeah.
If a patient responds well after their first episode of psychosis, what is the minimum time they need to stay on treatment to prevent a relapse?
To solidify recovery and minimize the extremely high risk of relapse after a first episode, the minimum treatment duration is recommended to be 1 to 2 years.
We really should dedicate some time to the side effects, because they are what often dictate compliance and long-term health. Let's break the extrapyramidal side effects into acute, chronic, and lethal categories.
A good plan. Let's start with the acute EPS, which can emerge pretty soon after starting the drug. First, akathisia.
Akathisia.
It's this severe, subjective inner restlessness, the inability to sit still. This symptom is clinically significant, not just because it's distressing, but because sources link it to an increased risk of suicide.
And the treatment for that.
It involves agents like beta blockers, so propranolol, benzodiazepines, or the anticholinergic trihexyphenidyl.
And then there's the medical emergency of acute dystonia.
This is a painful, involuntary muscle spasm that must be treated immediately. It can present frighteningly as an oculogeric crisis, where the eyes involuntarily roll up, or critically, laryngeal dystonia, which risks airway closure.
So immediate treatment is with
Antihistamines or anticholinergics.
Okay, moving to the chronic side effects, the ones that develop later on. We have tardive dyskinesia, or TD.
TD is defined by involuntary repetitive movements that develop after prolonged use, often involving the face. The classic presentation is sometimes described as perioral tremors, or the rabbit syndrome. Since this is often irreversible, prevention is really key.
But the treatment for established TD has seen some modernization, hasn't it?
It has, yes. The standard of care now utilizes VMAT2 inhibitors. That's vesicular monoamine transporter 2 inhibitors. Specifically drugs like tetrabenazine, deuterbenzine, and valbenazine, which help modulate dopamine transport to manage those uncontrolled movements.
And finally, we have to address the most lethal complication, neuroleptic malignant syndrome, or NMS. This is a life-threatening medical emergency. What are the cardinal clinical features that clinicians have to watch for?
NMS is characterized by a rapid onset of hyperthermia or fever, along with severe generalized muscle contraction known as lead pipe rigidity, and a rapid change in mental status leading to delirium.
And the cause of death.
When mortality occurs in NMS, it is typically due to renal failure, which is secondary to the muscle breakdown from the rigidity.
And the treatment for this life-threatening syndrome requires really aggressive intervention.
Absolutely. Beyond intensive supportive care, specific treatments include bromocriptine, amantadine, dantrolene, and in refractory cases, even electroconvulsive therapy. Prompt recognition is paramount to survival.
So what does this all mean for you? We've covered the entire clinical spectrum. I think the key knowledge nuggets here are that foundational shift from Kraepelin's focus on prognosis to Bleuler's focus on core deficits, and also the crucial realization that the mesocortical or negative symptoms are the major driver of disability and poor prognosis, and the definitive but very high-risk role of clozapine as the last line of defense against treatment failure.
The clinical reality of managing this condition is just a constant tightrope walk. You're balancing the high efficacy of agents like clozapine against the constant, potentially fatal risk of granulocytosis and metabolic compromise. We're managing complexity piled on top of complexity.
And understanding that reality raises an important question for you, the learner, to reflect on. Given the significant impact of compliance and family support on prognosis, and knowing that the most effective treatment, clozapine, carries major risks requiring constant patient involvement and monitoring, what level of societal or family intervention is most effective and ethical when a patient is facing a potentially chronic condition, and the only definitive treatment carries such major risks? How do we best support autonomy while ensuring patient safety and functional recovery?